I think I'll start just by saying that I don't have any disclosures relevant to this presentation. I'll come back to some others at a future presentation. So within 7 minutes, there's a lot to cover. I think the usual question that comes about to us medical oncologists is the role of taxanes here. So that's where I'll start. And this is a diagram that I was drawing for a long time in clinic for my fellows and finally put into our ASCO SEP chapter for fellows education. Just sort of struggling to put this whole disease space together. And I had to update it again now that AirNote data came out. Generally just sort of thinking about these clinical factors of de novo versus recurrent disease and high versus low volume as kind of clinical surrogates for true biology, right? And that's really what they are. We shouldn't think of these as truly defining disease response. So nobody in this audience probably needs this. I'll quickly run through just the gamut of trials, but this is sort of how I think of them. So we started out with Charted, showing maybe this difference between volume, but once we went to Stampede, only in the de novo setting, the volume didn't seem to matter. So perhaps that was really driven by the sort of more indolent, low volume recurrent patients. Then a couple of trials with abiraterone, also showing benefit primarily in a de novo space. And importantly, I just wanted to highlight Chris Sweeney's publication specifically in recurrent patients from the Enzamet trial, really highlighting that intensification still had a role even within those more favorable patients. And then finally, primarily in the de novo setting, the triplet data, what we're missing, of course, is the trial of ADT plus ARPI plus or minus taxane, which will truly let us sort of investigate what that role is of taxane in the modern era. So again, trying to put this together for my fellows, this was the diagram that I ended up putting into ASCO SEP. And so I just wanted to take us through a couple of these pathways. And this is in the process of being updated. I think that the challenge for today was really about de-escalation. And so I wanted to show two trials in progress, one from EORTC that's asking the question about intermittent therapy in the modern era, right? So the old SWOG trials were done with an ADT monotherapy. This is really being done with intensive therapy and looking at patients who have good initial responses. Do they need to maintain their therapy continuously, or could they interrupt that? And similarly from Dana-Farber through Alliance, Atish Chowdhury is leading this A Dream trial, which is kind of an observational study of patients who have good responses, come off therapy, and then have reinitiation triggers. So really trying to ask this question of, for these long-term responders, how much do we have to keep the pedal to the metal? I think what's really interesting, of course, is always biomarkers. I think at baseline, there's been a lot of interest in genomics from especially in the neoadjuvant setting. We've heard about SPOP as something that might indicate a very good response to AR-directed therapy. Maybe those patients don't need the taxane. In contrast, maybe loss of some key tumor suppressor genes predict for a less AR-driven biology and may have a clearer role for chemo. I think transcriptomics, we heard a little bit from a kidney cancer session this morning, sometimes a little bit more challenging to put into practice, but in the bulk lab at BI, there's been a lot of interest in a pioneering transcription factor called FOXJ1 that seems to interact with a downstream microtubule binding protein. And interestingly, this does seem to actually be a predictive biomarker in the Charted data. There's a great interest in trying to look at this now prospectively, should Alliance or others successfully get a trial off the ground involving the plus minus docetaxel. There have been a lot of CTC work done by others, something that was really surprising to me when I saw it on a poster, and I said, wait, these data have to be backwards, was that AR signaling going up after starting AR targeting therapy seems to actually predict for worse outcomes. We would have thought, hey, these are the most AR-driven patients, but it's actually that dynamic biomarker, that sort of response to initial AR targeting therapy. And if AR goes up in response to that, maybe those are the bad actors. We've been really interested in AR antagonist monotherapy. There was actually one of those Euromigos podcasts recently with Bertrand Tomble about this. And he's published a couple of data sets. Here's one with enzalutamide. There was another with darolutamide in sort of a mixed HSPC population. Clearly, they're very active. And clearly from EMBARK, we know that if you were going to choose ADT or an AR antagonist, you should choose the AR antagonist. I think that not everybody looks like the clinical trials in practice. So we certainly have a lot of patients who have significant comorbidities, may not die of their metastatic prostate cancer, limited performance status, especially those with sarcopenia. And there are patients out there for whom OS, maximal OS, is not the primary goal. They really value being off of medical castration. Some patients are really into their sexual function, and this is really important to them. So I think it's an option that we don't consider probably enough because of the FDA labels, but there's no problem in getting access to it. We've never had a problem writing a prescription for it. I think that we can only touch briefly on the role of local therapies. And this is mostly sort of an intensification question rather than de-intensification. I'm only going to put data up from Stampede, but I'm going to acknowledge that HORAD and PEACE1 exist. And so this was what sort of put this on the map. A patient population that was primarily treated with ADT, a subpopulation with docetaxel, and no OS benefit overall, but looking dangerously into subgroups, the low burden group seemed to have an OS benefit. This is, of course, separate from any benefit on sort of prevention of local badness. And that this was maintained with further follow-up and, has sort of put this on the map of our treatment landscape, but with a lot of caveats about subsequent data from PEACE1 not necessarily showing this benefit in the context of modern intensified therapy. So we have to be very careful about who we offer this to. And then in terms of treating metastases, I think of a couple of different scenarios. One is the sort of spectrum of disease from oligometastatic to high volume. Clearly, there's patients who need it for symptomatic mets or even some asymptomatic ones. There are also, this idea of going all in on oligometastatic disease. And scenario two, I'm going to come back to in my next talk in BCR, because I think that this is a very, very complicated space. But I think we should be very considerate about who actually needs treatment here, what the benefit of MET-directed therapy is, and how we handle within field recurrences. So I won't be able to tackle all of this, but I'm happy to chat. This is just a brief plug for supportive care, and in particular, our local prostate cancer support group that now has a website and online access to monthly Zoom meetings and slide libraries and videos. So that's everything that I have, and I'll stop there.